I'm with Dr. Richard Ruth, Associate Professor of Clinical Psychology in the Professional Psychology program at the George Washington University and one of the founding core faculty members of the LGBT Health Graduate Certificate Program. Richard, can you tell us a little bit about who you are and what you do in your professional life as a gay clinical psychologist?
Sure, glad to. I teach full-time here at GW. I teach people who are studying to be clinical psychologists, and most of whom want to become clinicians full-time. A few want to become researchers. And I have a practice in DC and suburban Maryland, where I do psychotherapy, psychoanalysis, family therapy, and psychological and neuropsychological assessments. So the range of things that many clinical psychologists these days do.
Great. And can you perhaps tell us about the process of becoming a gay mental health professional to serve LGBT communities?
Yeah, it wasn't easy in my day. Getting better now.
Yeah.
When I went to graduate school, we were using version 2 of the Diagnostic and Statistical Manual, the so-called Bible of mental psychological problems.
Right.
And in that, gayness was an illness. It didn't become not an illness until version 3. And it became not an illness not because scientists in the laboratory discovered something that, oh gee, we made a mistake by lobotomizing all of you for decades. It was because people like me fought it out.
Right.
And fighting it out as a graduate student meant speaking back to professors who were grading me, who decided whether or not I was going to be allowed to go along and get my degree and do the profession I wanted to do, and telling them they were wrong. So I think a lot of people of my generation have lived through that, and it accompanies us in what we do every day. Those memories and that process. There were colorful moments like disrupting a psychoanalytic meeting.
Were you at the San Francisco meeting in 1970?
I was not at the big one.
Yeah.
I was at a little one in New York, but it was really good. We had t-shirts, we had coordinated a dance number, and we just wouldn't let them talk.
Right.
They wouldn't let us talk,
Right.
and we wouldn't let them talk. And it's not something that I think is ideal in most situations, but in that one, heck yeah. And in the years I've been a psychologist, we've gone from me having to, with a pounding heart and terrified, say to my professors, I think you're mistaken, to people applying to GW because they know that some of us are here, and they're welcomed, and there's an affirmative climate all the way through.
Great.
And I forgot your question. So
Just about where you were in your professional career
yeah.
at the time in 1973 when the decision was made to turn. So a little civil
Right.
disobedience was sort of necessary at the time, I guess.
It was really necessary, and there were hundreds and thousands of us who did it.
Yeah.
And that's why the mental health landscape is different now from what it was then, in terms of learning how to do quality treatment and assessment with our communities. There wasn't anybody to teach me that.
Right.
My colleagues, my peers, and I taught each other. Figuring it out is how we went along. We wrote the theory, worked out the practice, and have been refining it as we go. And so to be alive in a time when there's an accumulated body of knowledge that you and I can teach our students in our certificate, that's beyond wonderful. Yeah.
So speaking of that accumulated body of knowledge and jumping ahead to today, what are some of the key mental health issues and needs in the LGBT community as you see it?
So it's a hard question to answer because just under the surface of it, the waters are real turbulent. On the one hand, we're no different from anyone else. 20% of people, at least over the course of a lifetime, will have a substantial mental health issue. About 50% of people will have a mental health issue that if they brought it to a professional, the professional would say probably, yeah, this is in need of treatment. Now, those statistics aren't firm because when you try to survey people about it, the surveys are not easy. You go to someone who is gay or lesbian or bi or trans and say, hi, I'm your friendly local researcher, as nicely, as professionally as you can, and I want to talk to you about your mental health. People are going to lie, or they won't show up for the interview, or they won't be willing. And that's going to be more the case in some sectors of our communities, people of color, people of low SES, people who aren't out, people who have sex with people of the same sex and don't self-identify as gay or lesbian or bisexual. It gets real murky. But those are rough numbers as best as we can come to from looking over an emerging literature. So we have the same problems everybody else has. And most mental health problems never get identified, never get treated, or if they do, don't get treated effectively. Not because there aren't effective treatments, but because they're not always done. Then there are some problems that are unique to our communities. Not because gayness is anything other than something to be celebrated, or having a different gender from the gender someone put on your birth certificate is anything other than something to be celebrated, but because oppression causes damage. And it's a tricky point to talk about, but if oppression didn't cause damage, we would be surprised, or it would be of a different category. It does. It causes confusion, it causes sadness, it turns people toward substances of abuse to try to ease the pain. It causes a lot of difficulties. Difficulties in relationships, difficulties developmentally, difficulties when we become parents or teachers, or all the things we become. So there's a disproportionate amount of depression in our communities. There's a disproportionate amount of anxiety in our communities. And there is certainly a disproportionate amount of substance abuse in our communities. There is also a disproportionate amount of what are called organic problems or neuropsychological problems, from chronic HIV sometimes, from the after effects of substance abuse, even when people are in recovery, from all kinds of things, including from untreated and undertreated medical illnesses that have psychological effects. And so when someone from our communities comes to a mental health professional, and we want to be thorough, and we want to be real, and we want to get somewhere, all of that becomes relevant. The developmental dimension is important. And it's complicated, but I've been practicing all weekend, so I might be able to explain it clearly. Normal part of development is that when children are about 4 or 5, they fall in love, if they're heterosexual, with the parent of the opposite sex. And that's what Freud discovered, and he was wrong about some things. He was really right about that. He called it the Oedipal phenomenon. A little girl, if she's going to grow up to be heterosexual, falls in love with dad, or a little boy falls in love with mom. And it's not like that John Travolta movie where the baby is thinking all these things, but it's for real. The feelings are real. And ordinarily, if things go on well enough, Dad doesn't divorce Mom and marry the little girl. Mom doesn't divorce Dad and marry the little boy. They work it out. It's sad. It's powerful, like all things in human development, and it's a precondition for moving on. Well, according to the path-breaking work of Richard Isay, a gay psychoanalyst who is of a generation before me and had to go through his training closeted and then came out and did amazing work, we go through the same thing. Only we fall in love with the same-sex parent who usually is clueless at best, hopefully not abusive, but clueless. And so in the developmental pathways of most gay and lesbian and bisexual and trans people, something happened early on where Mom and Dad didn't get who we were, or Mom didn't get who we were, or Dad didn't get who we were, or we were raised in foster care and no one got who we were. Our elementary school experiences are often difficult. There's a lot of bullying. It cuts as deep as it goes. When I evaluate, as I often do, kids who seem like they're on a trajectory to growing up to be gay or lesbian or bi or trans, I can see that pain while it's happening in a 7-year-old last week, in an 8-year-old and a 13-year-old. And that changes what happens to us. People don't become heterosexual naturally or automatically. This is the work of Nancy Chodorow. There's a huge social, cultural, religious, familial mechanism that teaches boys to be heterosexual boys, girls to be heterosexual girls. When people are in junior high school and the hormones are sprouting, there are school dances that are not designed to be inclusive of us. It's this huge social mechanism to teach you how to connect, to learn all the million things you have to learn to do that. If that doesn't happen for us until we're in our 20s, hopefully, then there's a developmental lag, which is a normal, ordinary part of LGBT life that most heterosexual people don't have to face. And that affects who we are developmentally, and it's what often people find it helpful to talk about in therapy, not because something is wrong with them, but because something was complicated and difficult, and they want to work it out. And mental health professionals know how to help people do that.
Gotcha. Well, understandably, then, some, if not many, LGBT people would be skeptical or wary about seeking out a mental health professional because they're all too aware of the fact that being gay is considered, a disease. How do you respond to that problem?
Well, so as a clinical psychologist, I'm both a scientist and a clinician. And the science only takes you so far, but when it does, it's very interesting. In many large cities, like D.C., the patients of mental health professionals are disproportionately LGBT. Like, we're big consumers of this stuff. So, like, if Sky Vodka can market to us, mental health professions should market to us too. They should train people to be really good at treating us because, like, who else do they think is going to come to their offices? And that's true for straight as well as LGBT mental health professionals. So it's kind of an interesting wrinkle. Little different in rural and more isolated places. Some of them, not all of them. I have a colleague who specializes in work with the trans community, and she works in a rural area. And she, with a twinkle in her eye, she talks about how people assume like she's not going to have any patients. She has a waiting list.
Yeah.
The number of trans people out there who, through their networks, our networks, know who's cool and show up at the door, it's robust for her.
Yeah.
She has a nice car, a nice house, great practice.
Yeah.
So people do come to us,
Yeah.
but people come to us with questions because we may think that we live in an age where all the big problems are solved. I live in Virginia. All the big problems are not solved. There's a lot of hatred, the old style hatred, and the more subtle problems we call microaggressions, little offenses of daily life that build up inside of us. So when an LGBT patient comes to a mental health professional, even if they know that we're LGBT, they have questions. And those questions have answers and deserve to be answered. And most often, when the professional is well trained, they do get answered. But it's important for prospective LGBT patients to, as much as possible, know what they're getting into. LGBT media in most areas will let you know who's out there.
Yeah.
And those are good starting places. Websites, connections, things you find out through friends. There's a delicate point that in a lot of kinds of psychotherapy, you don't want to project yourself too much into the situation so that the therapy can stay about the patient and not become about us.
Right.
I don't talk all about myself with a patient, even as much as I'm doing here. And yet most of my LGBT patients come knowing, which is fine. That's a good starting place.
Right.
There's a story I'll tell you that might give you a sense of it.
Terrific.
A couple years ago, a new faculty member joined us here in the program, and he was someone, a very well-known person with a great reputation, and I was really excited he was coming here. And then, after I got over that moment of excitement and was sitting in my office with the door closed, I thought to myself, I'm going to have to figure out if he hates me or not. Because the old attitudes live on in some people and some places, and I needed to know. And so that was one of the things we had to figure out together. In fact, the first time we got to spend some one-on-one time together after he came here, I found out he was a deep, solid ally who had done the work that he needed to do. And we had a wonderful relationship. But I had that moment of not knowing. And that moment is going to be with patients of all LGBT patients, really. Some patients might suppress it and then need some gentle help drawing it out, some space for that. Others are going to be really in our face about it, which is wonderful.
Yeah, yeah. And I imagine you have to anticipate a few questions as well as being able to answer ones as, when they come to you. Well, that leads to this sort of a pretty logical question. When an LGBT patient comes to you, what's your process? What happens? Like, do you have a different way of approaching working with LGBT people versus non-LGBT identified patients?
I think only in a very subtle way.
Yeah.
And sometimes subtleties are allowed. When I meet an adolescent for the first time and I'm getting to know them, usually that takes just an initial appointment or maybe a few. At some point, as with every teenager, I want to know about their sexual and relational development. Not the easiest thing to open up, but they're eager to talk about it, and with a little welcome, they do. If I make a heterosexual assumption, I'm not doing what I believe in.
Right.
Nor do I want to weird them out, to use a technical psychological
Right,
term.
right.
So I might ask in neutral language, are you in a relationship? And if they look at me quizzically, as teenagers, often have mastered the art to doing, and they want to see where I'm going to go, it might be, have you had a boyfriend or a girlfriend? And there are some heterosexual patients that take offense. And then the moment is, we live in the day and age that we both know we live in. So I asked the question and he answered it. Let's move on.
Yes.
And I remember saying this once to an 18-year-old football player who was decidedly heterosexual and much bigger than me. And you could see the emotions moving, and I answered just the way I just said I did. And he said, oh, yeah, okay. And then we went on. But that's the kind of moment that happens in psychotherapy in this day and age. Mostly it's a matter of making space in my mind for the range of things people might want to present. I was recently meeting a young boy for the first time, and I had spoken to his parents a few times before I met him. They had some concerns about his behavior, and they mentioned some gender variant behaviors.
How old was this child?
He was 7.
Okay.
And I won't be sharing too many details because confidentiality is important. And so they were both eager for and reluctant for me to meet their son. Wondered what the feedback might be.
Right.
And they became more worried and not less when this boy took to me in the first few minutes, and we were off and running, and they were sitting in the waiting room. And, I didn't want to get ahead of him by raising things, in part because I wanted to see how he would raise it. And if he would raise it, I wanted him to take the lead, which is a part of psychotherapy. Let the patient tell you who they are by setting their own terms. So, a little more than halfway through the interview, he said something about the way he likes to wear his hair, and a comment to the effect of that he liked girl stuff more than boy stuff. And my response was more nonverbal than verbal. I said something verbally, but non-verbally what he got is, that's just fine. That's just fine. And within about 5 minutes, we were able to bring into focus that he was a gender variant kid, technical term. And most such kids grow up to be gay. Some don't. Some grow up to be, I don't know, heterosexual florists or something like that. And some of them grow up to be trans. But this child's first experience of meeting with a psychologist was, it's fine to be who you are. And if there's any work to be done, it begins at that point. And the work with his parents will begin from that point as well. Something a little bit unexpected and perfectly healthy, perfectly fine. Our job is to figure out how to support him and how to teach his school to not let other kids bully him, which has been going on from the first moment he walked in. And that's not his problem, that's the school's problem.
Two-pronged question here.
Yeah.
Effectiveness of treatment. So are there particular, how effective is are medications, therapeutic approaches with LGBT people, and are there specific treatments that are perhaps better than others?
Okay, so let's break that down into psychotherapy and medication.
Great.
Both are very helpful, and both have some different dynamics to them. The last time someone compiled an encyclopedia of the different kinds of psychotherapy there were 484, and they haven't published encyclopedias since because you can't keep up with it.
Right.
There were new ideas, new methods that are developed all the time. Probably the majority of mental health professionals use what are called cognitive behavioral approaches to psychotherapy. Those are generally short-term, generally symptom-focused, generally very efficient. And I'm really glad they exist. They tend not to have results that sustain themselves. Now, of course, I'm partisan. I'm a psychoanalyst and a psychodynamic psychologist. But some of my best friends are CBT people, and it's fine. They're very valuable techniques.
Not that there's anything wrong with that, right?
There's nothing wrong with it. If someone has an acute problem, they need one of them.
Right.
They may not need one of me in the emergency room. A little oversimplified, but those techniques, while they have vital, invaluable roles, tend not to have lasting effects. There's a large research literature that says, well, psychodynamic techniques are mushy, except that there's also a large research literature that says they have the most powerful, the most enduring effects. And more we know through research in dialogue with clinical work what some of the moving pieces are, what makes that so. There's a curious thing that when most people think about being in therapy, they don't think about modern CBT-oriented techniques. They think about seeing someone once a week or twice a week and talking and being listened to in the ways that therapists are really good at listening to. That's what tends to help most people from our community. If what went wrong in someone's life is that they fell in love with their father at age 4, and father was clueless and tried to get them to play baseball or something like that. Not that there's anything wrong with baseball. I know you're a fan.
Yes.
But you know what I'm saying.
Yes, I do.
Then if they're anxious, a technique that lowers anxiety, or if they're depressed, a technique that lowers depression, is not going to untie all the complicated knots of what happened developmentally. Different kind of therapy will do that. Maybe mixing in symptom-focused techniques, maybe not. That's topic for another interview about the nits and grits of psychotherapy, but I hope it gives people an overview.